like that.
Hello and welcome everyone to PerfWeb 108, day one. I'm your host, Joe Basha, and we're going to start off with our standard opening remarks. You may notice that I'm sitting somewhat awkwardly, a lot shorter than I usually am, because Joe's got gout in his knee and hip, and I've got my leg propped up because it really hurts. Okay, let's get this done. Contact us at contact@perfusioneducation.com. That's the way you can do that. Our crawl bar that you see down there at the bottom, right there, that will come on intermittently throughout the case. Please go to whatever platform you're using, whether it's YouTube, please subscribe to our channel, give us a thumbs up, make any comments, where you're from, what time of day it is where you are. Those things are really fun for us to have, but liking us and or giving us a thumbs up and subscribing and sharing the section is at their channel is very helpful to us, and we appreciate it. It helps keep us coming, keeps us doing this, right? And do that with LinkedIn and with Twitter and Facebook and whatever platform you're using, right? Our MediWeb at X, Twitter, formerly known as Twitter. Then our MediWeb app, something that we're going to use it today, actually. Use it in the program, so I won't go through the entire thing. But if you go to your Apple store or you go to your Google Play Store, you can download it. It's $2.99 for the complete app, which has a lot of really neat features to it. We're going to be doing an update here pretty soon, and updates are always free, but it's $2.99. It's a real bargain, I think, for what you get with it. But there's another section, there's a section to it called the IV drug and dose calculator, which is incorporated in the full app, but is also a standalone app for those of you who might be nurses, ECMO specialists working primarily in the ICU and using a lot of drug dosing. It's a separate app that's only 99 cents. So you can do like a Christmas present for your spouse. If you're the perfusionist and your spouse happens to be the nurse, or vice versa, you can buy him or her the full app and buy yourself the half app, whatever the case may be. Our podcasts, you can go to whatever your favorite podcast streaming platform is. We're on all of them. And so you can listen to our programs. And by any chance, David, I didn't ask if you were going to be able to do this today, and I should have. Can you show us our new front page of our MediWeb platform with all the different programs? You can. You know what, dude? I don't know what else I could do besides say that you're the best.
And you put him on the spot too.
So this is the new. Yeah, I know he's perfect.
Yeah.
The MediWeb network. And this is going to be how we're going to evolve for 2026. And you're going to see that we're going to have a variety of different programs. Of course, we have an adult ECMO specialist course. We have various programs. In fact, Vivian is going to be doing, what's your program called again?
Vitals and Vibes.
Vitals and Vibes, that's right. Thank you so much. Sorry, I forgot that. And Samir is going to be doing Paging Dr. Samir. I'm sorry? Yeah, you can read the cards right there. Yeah. And Vicki Carlisle, of course, doing At the Bedside, and Becky Bolkovac doing Your Grounded. And we're looking to, as we move on with this and become better at these, will be podcasts, except PerfWeb will always remain what PerfWeb is. So these will always be live programs. The other programs are all going to be pre-recorded and then released on a timely basis so that you can anticipate and predict when you are going to be able to listen to those while you're driving around or just sitting at home doing nothing, or in the operating room, TAVRs, covering ECMOs, whatever the case may be. There's so many different ways or places that you can do it. It's so convenient. But that's going to be our MediWeb platform. MediWeb network platform moving forward. I'm really excited about that. Thanks, David. Okay, I think I have the opening remarks done, and we'll go ahead and jump into this this presentation, which is, and this is something that I picked this topic because it is clearly, I think everyone on the panel will agree, a continuously or continually evolving process to alleviate the shortage of organs for transplant that are needed. Did I say that in a way that makes sense? Yeah. But it doesn't come without challenges, and it is a process that, by the data that currently exists, is very compelling as to its efficacy for actually doing what it's supposed to do. So I'll move on from there, and we'll go ahead with the next slide. So our goals are going to be to look at the physiology, the perfusion targets, the outcomes analysis, as well as some of the ethical concerns that could arise and do arise actually with this process. So this is why we're here. There is a significant wait list for organs and a shortage of organs in the United States. By the SRTR data 2023, there were over 103,000 candidates waiting for organs, while approximately 6,300 patients die annually on that waiting list. Now, nobody's dying from probably lack of eyeballs, but we're talking major organs when we're discussing this. I've tried to tease out any of the non-essential major organs, non-major organs, as best I could. Normothermic regional perfusion, otherwise known as NRP, has potential to rescue many organs lost to warm ischemic damage. And we're going to discuss that, and there's some really interesting data on that. Outcome impact, improved graft function. This is what we wanted to do, and we're going to see if it does. Reduced discard rates and extended organ utilization windows. Those are all three important elements to successful organ transplant for patients receiving those. Waiting candidates, kidney dominates incredibly, with 89,000 candidates waiting for kidney transplant at any one time, with the longest wait times 3 to 6 years from the largest cohort that was published.
Do you think that long wait time is due to the fact that they can do dialysis and just live longer without
Absolutely,
kidney?
absolutely, absolutely, no question about it.
Yeah.
The liver, 10,500, and the heart, a little lower at 3,500, but it's high urgency status, and those patients have the highest, the most rapid progression to death or need for a mechanical device until they can get that heart, or a new mechanical device until they can get their heart. There's a lot of other elements, of course, involved in this. Lungs are 1,200, critical condition, shortest tolerance window. So the waiting candidates is lower, not necessarily because there's fewer of them. It's lower, and that includes the heart. It's because they die a lot faster. And that's why the waiting list is not as high.
Right.
Because you come off the waiting list when you die.
Yeah.
So, and then for multi-organ, that would be liver, kidneys, could be liver, kidney, lung, liver, kidney, heart.
Lung heart.
I mean, there's
lung heart is popular.
yeah,
combination.
yes.
Yeah.
Well, you know, there's, and that's something else too. But those are complex cases. I do want to make that point, and it really takes a specialized teams. There's not just one team. There's a liver team and a kidney team, or a heart team and a kidney team that work together, lung team and kidney team, whatever the case may be. But, you know, we talked about this in different presentations, and that's organ crosstalk. And cardiorenal syndrome is real. Hepatorenal syndrome or hepatocardiac syndrome is real. But for the lungs, if you clamp off the renal artery and just occlude it, lung water increases exponentially over time.
Correct, yeah.
It's because, and
Same
it's
with
a
dialysis
it's
patients.
a very interesting phenomenon. And just by clamping it,
Yeah.
just take an animal, take a mammal, have them opened up, be doing your measurements, clamp the renal artery, lung water immediately starts to rise.
Yeah, that's why CKD patients, you got to really watch out for pulmonary edema, right?
You
Like,
do.
That's
You do. Wet lungs is very common in those patients, absolutely. Here's the U.S. transplants performed over the years from 2014 to 2024, and you can see that there was a leveling period here, and that's undoubtedly COVID related. But the point here is that we are continuing to increase the number of transplants being done, not only because of the increased availability of organ donors because of people who are brain dead, but also because of increasing technology to take patients otherwise not suitable for transplant or not brain dead, but are still going to die, and capturing those organs. So both technique and opportunity for increasing the donor pool is why I think we have seen this continued growth over the years. So the term CDCD, controlled donation after circulatory death, can be done either by rapid procurement or by NRP. So here is essentially the process. In the clinical setting, you have a planned withdrawal of life support time in controlled operating room or ICU or PACU or whatever place they plan on doing the withdrawal of care, with full medical team and family present. All measures to support life are withdrawn. That includes IV fluids, medications, ventilator, anything that would be used to assist the organism or the body, the human, the person, to remain alive.
ECMO as well, I would assume.
ECMO as well, yes. You withdraw everything, anything that's being used, so ventilator, ECMO. That's a very good point, because we do take patients that are on ECMO, and you turn the ECMO off, and they mostly do die very quickly.
yeah, those usually do go.
Those usually do.
Yeah,
And there is
and fairly quickly.
and
for
I
the
hate
most
to
part.
say this, it's kind of morbid, but reality. That it makes it a little easier for us because they're already cannulated.
Yeah.
I was just about to say that.
It's
yeah,
true.
You just connect straight to that with some straight connectors, and it's nice.
Absolutely. So then, once death occurs and it's been declared, there is a circulatory arrest with a 2 to 5 minute no-touch observation period per protocol. And then death is declared by circulatory criteria a second time after. So you have either PEA or you have asystole, VFib, whatever it is, and you have a clock that starts at that moment. In some states, it's 2 minutes. In some states, it's 5 minutes, and in some countries, vis-a-vis Italy,
I was just about
it's
to say,
20 minutes.
I knew you were going to bring up
right?
Italy.
It's 20 minutes.
Yeah, it's 20 minutes.
And this time frame is used to assure that the patient's heart is not going to return function on its own. After the standoff period is completed, whatever time that is, a second listen is made, and a declaring practitioner then states that it's the time of death. That becomes the actual time of death, not when the heart first stopped, or PEA, whatever it is. It's the second listen and the second assessment that determines that death actually has occurred. Now, that second listen can be, for example, you have the patient in the PACU. The PACU is generally juxtaposed to the operating room. The heart stops, and the first report of that is made. At that point, the families are usually escorted out, and the patient moved to the operating room
Very quickly.
and put on the table, and then at 5 minutes, the second assessment is made, at which point, being that you're already on the operating room table, prepping is done rapidly, generally a rapid prep with just a bath of betadine at that point in
It's
time.
basically, they just dump it on them pretty much.
Pretty much.
Yeah.
And then the procedure will begin at that point.
Yeah.
Now, there's a variety of things that you do. For example, prior to withdrawal of care, the patient is given a dose per hospital protocol, not OPO's protocol, whoever the OPO is. Each state has their own. Some states have more than one. But the patient is given 30,000 units or about of heparin, sodium heparin, and that 30,000 is also added to the NRP circuit, which is essentially a hybrid ECMO circuit. It's just an ECMO circuit with a reservoir, but not, well, it's almost like a mini cardiopulmonary bypass
exactly
system.
what it
Because
is.
It's a
Minus-
reservoir, it's everything, even if
Minus the
suckers.
roller suction heads, it's pretty much.
Right,
that's
exactly.
what
And
it
you
is.
could actually use that too if you wanted
You
to,
could,
and probably
correct.
would make it better.
Yeah.
It just would increase the cost too much. That's probably why they don't
would.
want to do that.
Yep.
Not quite as mobile, if you will,
Yeah.
because this stuff has to travel to
I was gonna
hospitals.
say,
We go to where the
also-
patient is, right?
Also, I think into real estate, it would make the pump too big. And in some of these ORs, you're pretty crammed in there.
Yeah.
Especially if there's a lung team, a heart team, you know?
This is very true.
Those cases are nightmares.
So at that point, this is a rapid recovery, you would start the surgery and gain access and immediately flush the organs with the solution that they use for preserving them, clear the blood out, get them cold, and then explant the organs, put them on cold ice in a bag in an ice chest, and ship them on their way. That's rapid recovery. So what you have in that circumstance is death or agonal time, where the organs, the heart is basically not working well, but it's still working and not perfusing well, and the patient is dying, and the organs are suffering
Yeah.
a great deal from severe hypoperfusion for some period of time prior to the death that occurs.
Yeah, some of these patients can hang on to that agonal phase for some time, too.
Correct.
Yeah.
And that's referred to at that time plus the time of total death and opening the chest and getting the patient open. That's all referred to as warm ischemic time. And the longer you have warm ischemic, ischemic time, the less viable your organs are going to be. So the limitations are what I just said: warm ischemia challenge, increased discard rates. There's a higher proportion of recovered organs discarded due to warm ischemia damage, especially the liver and heart, which are very, very sensitive to warm ischemia. Delayed graft function, or prolonged DGF in kidneys and reduced function in other organs compromises early post-transplant outcomes. And you have limited to no real assessment of organ function prior to the actual procurement or explantation of the organ, if you will. And so it's increasing this uncertainty risk, if you will. I hate to ask what that is.
I'm scared.
Okay,
Let's just carry on.
it's the light.
It
Okay,
is.
well, we need to take the, we'll just leave it, it'll stop eventually, but we
That's
really
that fan
should
you were
just,
talking
can we
about?
just disable those fans at some point in time, Magic? Can you hear it on the thing? It's over here. No, it's okay. Can you hear it? No, if you don't hear it, then I'm not going to worry about it. Don't worry about it. We'll deal with it later. I would just disable the fans. Okay, so the NRP core concept, in situ restoration of oxygenated warm circulation to thoracoabdominal organs after circulatory death declaration to enable reconditioning of these organs. They don't like to use reanimation. They like to use the term reconditioning. They're very specific with their language.
That's that ethical portion that we're going to get into later, probably.
Absolutely. No,
Yeah.
there's no question. There's no question about it. That
Yeah.
is very, very, very true. But with that said, we have that as a concern, but you can do this now with that. It's an ECMO-style circuit or a miniature bypass circuit. You can go online and see what they look like. I didn't bother with looking at what the circuits look like. But you have venous drainage, a mechanical pump, an oxygenated aortic root return circuit, deliver warm oxygenated blood systemically. Now, it says aortic return, not aortic root, aortic return. So it can be retrograde, it can be antegrade. It just really depends on whether you're doing purely abdominal or you're doing thoracic. Are you going for the heart and lungs, or are you just going to be doing abdominal? And of course, you have to take into consideration the capabilities of the surgeons, the cannulating surgeon, to be able to put those cannulas in. The dynamic assessment, I think, is what really is a key feature to NRP. You can monitor organ function in real time. You basically, to look at viability, you can do labs, you can do biopsies. There's so many different things you can do. But what I find to be remarkable is when you have a person that has been essentially agonal for 20 minutes, heart stops, 5 minutes of standoff, incision to cannulation, another 3 to 5 minutes, and sometimes longer if they run into trouble.
Absolutely.
And everything literally looks so gray and so dead.
Yeah. Even that
And
venous
then-
blood is almost black when it comes back.
Oh
in
my
those
God, it's
cases.
incredible.
It's
Yeah,
incredibly.
it's darker than your
Yeah, it
darker
just
than my
comes back
jacket.
and you're
it's
so
darker than my
scared. You're like,
jacket.
oh my God.
And then we start perfusing, and we watch things that weren't bleeding starting to bleed. It wasn't those lights. I just don't know why you just don't leave it. But forget it. Don't worry about it. Do whatever you want to do. I was perfectly fine and content with it the way it was. Okay, thanks. And I kind of lost my train of thought. Yeah, and then you look in the belly and you see the bowels actually start moving again. You see the peristalsis.
Absolutely.
Everything pinks up.
Yeah.
We look at the urimeter. They
Yeah.
start making urine.
Yep.
And it's amazing to watch the blood coming back from the venous that's black.
I know. It's
And then all of a sudden you just see it getting, the venous
Yeah.
saturation going
Going
up
up.
and watching that color improve. It's really, really,
Yeah.
really remarkable. It's impressive to watch.
And since you're
I
not-
always find it fascinating.
Since you're not perfusing the whole body, that venous color gets pretty red for
It
the
does.
most part.
Well,
I
and
mean-
that's another really good point, Samir, because I think that the cases that I've done, and I've done quite a few now, not as many as you, but I've done enough to sort of form an opinion
Sure.
that the more I can flow, well beyond, if I could get beyond
Yeah.
let's just say it's pure abdominal. We'll talk about these numbers here in a second, but if I could get more than 2/3 of my predicted flow for total body
Correct.
for just abdominal, and I can get to, instead of 66% of that calculated, I can
Like-
get to 74,
Absolutely.
75% of it.
Yeah.
Additionally, dude, these organs just do so much better. There's no doubt that DO2,
Absolutely.
is the key.
I mean,
There's no question.
I've had a case in the past, Joe, where, it was not that equation that we all use, that 66% of the 2.6 index.
Yeah,
it,
let's
it
go-
was
let-
not the case.
Can I write it?
Yeah,
Can I just write it here?
yeah,
So
yeah,
this
yeah.
is what is
write
sort
it.
of a kind of a protocol. Okay.
Yeah.
You take the patient, the BSA times 2.6,
Which is their cardiac index.
right,
Yeah.
index,
Mhm.
and then you if you're doing
Abdominal. cannula.
thoracic
Right.
and abdominal, then you multiply that by 0.75.
Correct.
And if you're only doing abdominal, then you multiply it by 0.66.
Right.
So just
Yeah.
in if you had, but if 2.266, let's say you had somebody with a BSA of 2, that would be 5.2. 66% of 5.2 would be, I'm just going to say it's 3.6. I don't really know the damn number. 3.6. If I can flow 4.5, I'm going to have a better run, and I'm going to have better labs, and I'm going to lower the
So,
lactate and the
you
glucose
will.
and everything else, and those cases do better.
So that's what I was getting
When I
at,
just
you know?
stay at the bare minimum or less, I don't.
No.
We don't have the same outcome.
No, so that's kind of where I was going, is that I had a case, of course, let's use your numbers you figured, that you came up with, my target was about 3.6,
3.6.
okay? I went on, the warm ischemic time was relatively short, patient passed relatively quickly.
And that
so-
makes a difference too.
Oh, absolutely, because my starting
the
lactate was like 9.
The shorter your agonal period,
Yeah,
the faster your surgeon can cannulate,
right.
the better they're going to do.
So my time was only like, my ischemic time was so short that my starting lactate was only between 8 and 9, so it wasn't really that high.
Up at 9.
But I went on and I flowed my 3.6, 3.7-ish. It wasn't budging the lactate. Like 20 minutes, 30 minutes in, my lactate was still only at like 8.6, 8.7. It was going down, so that was at least good.
But you
so,
have to make sure that's not delusional.
So that's what I'm getting to. So surgeon's like, is there anything you can do to get it down? I was like, the only way is we're gonna have to increase our DO2. So I didn't have enough volume to increase my flow. I was like, let's drop some blood. That will increase my lactate temporarily, but I'll be able to flow higher. I will be able to
Deliver
add
more oxygen.
more hemoglobin. I'll deliver more oxygen. That case, because I added 2 units, even despite people like first being like, no, don't do it, no, don't do it. Sometimes you have to. I ended up bringing my lactate down to about 5,
Yeah.
in about 30 minutes.
Yes, absolutely.
So,
There's no question about it.
Sometimes you just gotta, be on the fly. Change
there's-
DO2, like you said, DO2,
Absolutely.
DO2, DO2.
Listen, as far as I'm concerned, the key to perfusion, whether it be for cardiac surgery or whether it be for organ, what did I say the term was that you like to use?
Reconditioning.
Reconditioning, thank you. Reconditioning. I'm getting old too. There's a little bit of dementia there. But it doesn't matter what you're doing it for, even ECMO, VA ECMO. It's DO2, DO2,
Absolutely.
DO2. That's it.
That's it. Yeah.
That is it.
Especially if your situation's not changing.
Now,
If you're
sometimes-
seeing that you're not getting any better, then your DO2 is the problem.
Yeah, and
or the liver, but that's besides the
Exactly,
point.
and we also have to, and I don't mean to, because I say that with some level of I don't know what the word would be, but there's a caveat to it.
Mhm.
Sometimes when we're in the operating room and we're doing cases, we sort of have to accept an inadequate DO2, right?
Yep.
And so, transiently, it's not going to cause the demise of the patient. It may cause some additional renal injury. It
Yeah, I
could
was gonna
cause,
say.
other issues perhaps.
Mhm.
But at the end of the day, if they can't do the operation
They'll die.
because your flow is restricted,
Right.
but
AKI
we
is not your
shouldn't.
biggest worry then.
But it always has concerned me. It's always concerned me at how incredibly resistant people are to wanting to give the patient a transfusion
Oh, yeah.
when every indication of the patient's physiology, laboratory analyses, cerebral oximetry, whatever, says you should give this patient blood.
The cannulating surgeon did not want to give. I was like, listen, either the accepting facility really wanted us to bring that lactate down. They were about to turn it down.
Yeah.
I was like, either they don't take this organ or we do this. I made it very clear to him. I was like, this is our only shot now, and we did it, and it went down, and they accepted. So DO2, you can't fight DO2.
So doing the NRP, you have femoral and or central cannulation techniques enable the establishment of flow to the organs. Venous drainage is either going to be the IVC via the femoral vein or right atrial approach. It says gravity-assisted or active drainage. Okay, we use very active drainage. We use a lot of vacuum drainage. Okay, we use VAVD to its maximum capability using Neptunes. We don't play. We're getting back. We're getting drainage. Perfusion circuit is a centrifugal pump. It says membrane oxygenator, but we don't use membrane oxygenators. They're microporous hollow fibers. But the people that publish information always call them membranes. We don't use membrane oxygenators. We use hollow fiber microporous oxygenators. That's what we use. You need a heater because otherwise it's not normothermic regional perfusion. It's instead hypothermic, and inline monitoring, which we don't use. Anticoagulation is managed throughout the perfusion. That is not actually correct. I'll have to correct this, and I have the reference for where this came from at the end of the slide. But at the end of the day, we give the patient 30,000 units up front. We give them 30,000 units in our circuit. I have never run an ACT. Will likely never run an ACT for an NRP case. And then the aortic return goes into the arterial vascular system, either through the aorta or the femoral artery. Oh, very important. When access is made, whether it be abdominally or thoracic, if it's thoracic, they're going to apply 1 or 2 clamps across the arch vessels in order to exclude the cerebral circulation. If it is femoral, then, or retrograde, they will either use a coda balloon and occlude the aorta that way,
Hate those things.
or they will do a thoracotomy incision and clamp the descending thoracic aorta in order to exclude circulation back up towards the head. It won't go to the heart then either, but really the issue has more to do with the head.
Yeah.
And we'll get into it when we get into the ethics, because remind me to talk about that, please.
Yeah.
This is a very good slide. Warm ischemia impact on organ viability. So, if you take the heart, for example, which is extremely sensitive, which is this color here, and you look right here, you can see how that's a terrible arrow. I'm just terrible at drawing.
In my experience, the warm ischemia
Right here
is the main reason they decline.
This is what happens to the heart over the period of time in minutes in terms of its relative viability, okay? If you put that heart on NRP, it is the white line, which is...
It's there on top. So
right.
It's harder to see.
Yeah, it's real hard to see. Can you see it? Let me zoom in on it.
Yeah, there it is.
Yeah, right here. Okay? So look at the difference in viability. Let me do this there so you can see it really good. That's better. Now let's look at the liver. Dark blue, here's the liver here. This is without NRP, just rapid recovery after donation, after cardiac death, circulatory death. The light blue, look at the difference in terms of its viability. That's an enormous difference. And this is of course, this is your viability. and this is your time, right? And then the kidneys, if you take a look, with just straight DCD, you have, that was the heart. I think I messed up my line here. Well, right here, just look at this kidney with NRP. I can't figure out which line it is. Oh, there it is. I think I messed up. This is the heart, this is the kidney, and this is the kidney way up here, the purple, way up here in terms of viability when you use NRP. Those are pretty compelling numbers. That's a very compelling graph. In my view, when I look at this, I say to myself, NRP is a good thing. We should do NRP. There's no question about it.
Yeah.
So I think that the science is there. I think the data is there to warrant its use.
I mean, anything that decreases your arm ischemic time makes sense that it would be a good thing, you know, but again, we'll get into why people think it's not a good thing probably a little bit later.
Exactly.
Yeah.
For those organs that are in fact implanted, you look at this is many of these organs that are down here after time aren't going to be used. But when you look here, of those that are in fact transplanted, DBD, which the patient or the donor acts as their own NRP circuit, right? So there is no agonal period for them. That's over here. And if you look, it is so incredibly minimal that I think it is safe to say that it is equivalent between DBD, traditional DBD, and NRP after DCD. If you look at traditional controlled donation after circulatory death, you see what looks like a significant decrease in the organ function postoperatively in terms of 1 year survival of the organ. So it does make a difference of those that were in fact, because of these organs that are implanted, these are going to be very short agonal periods. They die right away, they flush the organs, do a rapid recovery, and they go on their way. There's not a long agonal period. So this graph, though it doesn't appear as dramatic maybe as you would think, is I think lacking in the ability, because they're not going to implant organs that they know are not going to work.
Exactly, yeah.
So it limits that ability to really see the difference. You would have to do a very large animal study to really, I think, get data that would be more visually compelling.
Those organs that ultimately don't get used, they usually go to organizations like Live on New York. And
Oh, they do?
I think so.
Tell me about that. I don't know about that.
I remember my research lab that I was in at Columbia. We would consider it controlled tissue because technically the tissue wasn't diseased.
Mm-hmm.
So we were able to work out a way where if the organs weren't able to get donated to somebody, we worked with Live on New York so that we could use them for research study and we can.
Oh, okay. Well, that makes sense.
Yeah.
That makes a lot of sense.
Yeah, it was helpful for what we used it
Question for you.
Mhm.
Do you have to buy them? Does Live on New York have to buy them?
I'm not entirely sure, actually.
I'll bet you they do.
Yeah.
I bet you they do.
They do.
Because those
It's the world we live
OPOs
in.
those OPOs are not going to lose money.
Yeah.
Yeah.
You want this for research? No problem. It's a discount, it's a reduced rate. It's a special today just for you. Yeah, so you're paying for it, I have no doubt.
Yeah.
Okay, so the workflow and oversight, you've got donor team roles, which you can read here. You have perfusion team roles, which I'll maybe focus a little more on. You get the circuit ready, and you have to have it ready, fully ready, before withdrawal of care.
Yes.
Because if you don't, once that occurs, especially if the withdrawal is in the operating room, where there's not going to be any time, even from the PACU to there, you don't have time to put this circuit together and prime it and get it all ready to go.
No.
It would be impossible to do because that time from declared death, standoff period, and then starting the procedure is chaotic.
It's
There's
very
no question
chaotic,
about
yeah.
it. But you get everything prepared, you put the blood, usually what I'll do is hold off putting the blood in
I do too, yeah.
until they have passed.
I
But
do the same.
there's a lot of patients that end up not dying or donors that don't die. And so all of it gets thrown away and wasted. So in the OPO's defense, they do lose a lot of money on a lot
Yeah.
of cases that don't actually occur.
And I found that from time of incision to time of cannulation, that's enough time in there. That 3 minutes, 4 minutes, 5 minutes that you have, it's enough time to drop your blood and all that.
Absolutely.
Yeah,
It's-
I've never stressed on that.
And
I've
what
done
I'm-
it in every one of mine. You know,
And
that I
what
do.
I've started to do to try and save, just to try and save money, not because not because I really care about the OPO per se, but I care about our healthcare system. I care about
Sure.
the whole, right?
Mhm.
And what I'm doing now is figuring out up front, okay, what's this patient's probability of dying quickly? And if it's not high,
Mhm.
I won't even add the drugs.
Yeah.
I will wait. And once I see that the patient is, or the donor, I keep saying patient, the donor is starting to decline,
Sure.
I'll go in there real quick, drop the
Drop the
drugs,
drug.
drop the blood, because I'm like, okay, it's going to happen.
Yeah.
But if they're just going along, doing
Yeah.
well, and I'm like this, and it's like 40% at least
Yeah.
that don't pass.
No, absolutely.
It's at least 40%.
And you can tell too, like you said, there's
Yeah.
signs
That-
that
right.
you can see,
Right,
and you're
because
gonna
you're-
know what
and you're
type of
looking
weight
at
you're
these
in
numbers
for.
every minute.
Yeah.
And then you have the organ transplant team's role in terms of assessing the organs and doing the biopsies and all of those things.
Mm-hmm.
But coordinating, it takes about time. It takes about 15 to 30 minutes to fully set the circuit up. And then the perfusion time can be as low as 20 to 30 minutes if you're only going for kidneys and they recover rapidly. But it can also be somewhat longer than 120 minutes, though that is unusual. I have heard of 3 or 4 hour NRP cases.
I
But-
feel like the longer ones always have some other stuff involved, like you're either waiting for biopsy results or something weird going on in
Right.
the background.
Right. And then you have, you should 100% of the time, you should be thinking about and focusing on safeguard compliance. Organ assessment, functional testing, selective biopsies, expedited procurement with recipient coordination, performing visual checks of everything, obtaining the biopsies if protocol indicates, review the histologic findings, coordinate cold preservation and recipient surgery timing. So all of these things are very important.
Yeah.
But it's important to use safeguards because there are ethical issues which we'll discuss here. Perfusion target parameters, you want a mean arterial between 60 and 75 to have an adequate perfusion pressure and support microvascular flow.
But
want
you very
your
rarely
abdominal-
have an art line, so let's make that very clear.
You'd say that again?
Very rarely do
Very
you have
rarely.
an art line
That is
to
true.
even know your map.
That is true.
Yeah.
That is true. And I hate to say it, but a good surgeon can put their finger on the aorta and tell you what the pressure is.
Absolutely, yeah.
Abdominal flow rates are between 2 and 2.4 liters per minute squared of the total body. That's higher than what 66% for that of that the total BSA our protocol is, but I go outside of that protocol in terms of increasing that flow regularly.
Me too.
It just depends. This flow might be needed if you are running hemoglobins of 5 and 6,
Yeah.
which I've seen many times.
I always flow as high as my circuit and my volume will allow.
That's fair. Core temperature, 36 to 37 degrees. And this basically just supports normal metabolism. Venous oxygen saturation between 65 and 75%. We don't measure it, but I look at the line and I'm pretty good at being able to, guess what the venous sat is. I'm really good at it, actually.
Yeah.
I like to take the younger students or the the new PAs or whatever, and I'll bet them. I say, "What do you think that SvO₂ is?" And they'll come up with some kind of a number, and I already know what it is.
Yeah.
And I'll say, "Well, I'll bet you." I said, "I bet it's between this and this. What do you bet?" And they'll come up with a number, and I always win.
40 plus years, Joe.
I know. Serum lactate goals, you want it to be less than 3 or 4, or not or trending down.
Sure.
You could start off with a lactate of 17, and if it's gotten all the way down to 8.5, you're not going to stay on and try to get it to 3 to 4 because you can do more harm than good.
Exactly.
So you take your win. And if it's going down, that's a great sign. Also, glucose levels.
Those should go up.
You want those glucose levels to be pretty high
Yes.
at when you do your first one, but you want to watch that continue to go down. Another very good indicator that the liver is functioning as it should. You don't want to see it just plummet to 0.
No.
And you don't want to see it stay 500. You don't even want to see it at 5. You probably want to see it probably between 400 and 500 would be pretty normal. Kidney NRP acceptance algorithm. You can take a look at this. Establish NRP. Achieve target perfusion parameters within 15 to 30 minutes. Monitor urine output, and it's just amazing to watch the pee. And especially when it's high quality, really clear pee.
Yeah.
It's just amazing. Declining lactate indicates viable kidney. Assess for gross discoloration, and consider optional needle biopsy if function is borderline. Proceed if histologic findings are acceptable, and then standard cold flush for transport. Now, let's get into the ethics of all this. That's all the kind of
There you go.
rigmarole in science. NRP practice depends on rigorous adherence to autonomy, beneficence, non-malfeasance or malfeasance, and justice principles. Autonomy, informed consent for both the DCD and NRP procedures is essential. With transparent disclosure of risks, benefits, and alternatives to families. The beneficence, maximize life-saving organs recovered, benefit recipients through improved graft function and reduced waitlist mortality. And then non-malfeasance and justice, prevent brain reperfusion via arch occlusion, ensure equitable allocation, transparent governance and registry oversight. I'm going to focus a little more on this. This is critically important, obviously.
Oh, yeah.
Okay, and this is also critically important. But this is, for the sake of my discussion here, super important. I have to say that of all of this, my focus may not be your focus, and I'll explain to you why, because I'm curious what you guys' opinion about this is. My major concern is that we ensure there is equitable allocation and transparent governance and registry oversight. In other words, who should be getting that organ is who should be getting that organ, as opposed to who is more privileged. That's what I'm most concerned about. I have been doing this for I don't know how long. I do know how long, but I don't want to say. I have never had an occasion where a patient, a person, has been without blood flow at all for 7 to 10 minutes as a minimum. Because in these cases, again, you have the agonal period.
7 to 10 is like they're getting on quick. At 7.
Right.
Yeah,
so, but you have the standoff period of
That's what I
5
mean.
minutes.
Yeah, that's true.
And again, in Italy, you have 20 minutes.
True.
And most of the time, we're not on bypass in 5 minutes. We're not on NRP for, so 5 minute standoff, do everything. It's probably 12 to 15 minutes before we're actually on pump
Yes.
or on NRP. The brain's not going to come back, but there is such an incredible concern for this. And I feel it is sometimes overcomplicating what we do. If the coda balloon is leaking just a little bit and you have some flow that might be going to the brain, maybe, it just doesn't concern me. They're dead. They're dead. They didn't do 15 minutes, 13 minutes, 14 minutes, 15 minutes with zero blood flow at normothermia. And that brain is going to somehow come back. There's just...
Especially with the leaking flow. That's not even full flow.
Correct.
That's just like a little bit.
Well, that's
here
exactly
and there.
right.
Yeah.
But it has become such a third rail.
Yeah.
So what's your opinion about that?
Well, I read a paper recently covering the ethics of NRP, and they cover resuscitation and death determination. And the argument against that NRP seems to upset the controlled DCD death determination framework. A couple notes that I took down was that, like, the donor has been declared dead, so no other subsequent action could invalidate death determination, because that would be like a contraindication. You have a dead donor made dead, no organ retrieval can cause death in a dead body, is the argument.
So is the dead donor rule.
Right.
Right, the DDR.
Right. And then reinstitution of circulation technically invalidates death determination. So it ignores like the rule of intent. So if you want to resuscitate a patient, they argued you have to intend or make resuscitation the intent,
Yes.
which is not the case here.
Correct.
So that's like a couple things that I found.
Yeah, and it's just, yes, and that's the problem that I have with it is, though I understood everything you said,
Yeah.
but everything you said doesn't make sense to me. Does that make sense?
Yeah,
Do you
sure.
understand? What do you think, Mel?
What was the question?
My lack of concern about not initiating NRP before you've isolated the cerebral
Right,
circulation, or you freak out because you might have a leaking coda balloon and some flow is going up towards the head, that after 12, 13, 14, 15 minutes, that brain is not recoverable. It is completely, absolutely, utterly done.
Yeah.
So I don't get that. I feel that the over exaggeration of that concern creates technical challenges and actually increases the length of time that these organs endure warm ischemia.
Yeah, I think there's bigger fish to fry.
I think so too,
Yeah.
and I'm assuming you feel the same way.
Oh my God. I mean, I worked in stroke, dude.
Yeah.
So
Yeah,
I know when a brain is dead, okay? Like,
Yeah.
it is not coming back.
Dead's dead.
In all
Yeah.
of my career.
Yeah.
And I worked in India, so these are a lot of patients I've seen. Yes, I only worked for about 7-8 years, but just the sheer magnitude of 1.5 billion people, I used to treat anywhere from 100 to 150 people per day.
Yeah.
So, man, I've never seen, Joe, I've never seen
Well, I
somebody
mean, if
just
we
all of
take-
a sudden spring back up because
If
of...
we take a clamp, and we don't even stop your heart, just take
Yeah.
clamps and clamp your carotids, okay, your
quickly.
your carotid arteries, and we unclamp them. If we take 1 million people and do that to them,
None of them are going to
there will not be one
No.
survivor.
No,
Exactly.
no.
Not
I've
one.
never seen it.
So I don't
No.
understand why it's so. Okay. Arguments supporting NRP: respects donor autonomy and intent, substantially increases organ availability, reduces wait list, mortality, improves graft outcome, decreases organ discard rates. Evidence-based protocols, rigorous oversight, registry monitoring, and public engagement effectively mitigate ethical concerns. Arguments against: public misunderstanding of procedures, potential for misuse if governance is weak, requires substantial infrastructure and training investment. Key safeguard factors: clear legal framework, independent death declaration, arch occlusion documentation, transparent informed consent, and institutional ethics review. So, not naming names,
Sure, don't name names.
but there are people that I think we have at times seen that, because there's very strict rules.
Very.
The patients, you don't touch these patients. You do not touch them until the second declaration, the actual declaration of death, after the 5-minute stand-up period. Heart stopped, 5 minutes, heart still stopped, it didn't auto-resuscitate, dead. There's your declaration of death. From that point backwards, no one involved in the NRP team is supposed to have any contact with that patient. But we've all seen it.
That's why she looked at me and laughed.
And that's a problem.
That is a problem.
It's not perfusion to the brain that's the problem,
Sure.
after it's been dead for however long it's been dead. That's the problem. It's not following established safeguards.
Right.
Something that concerns me. Diverse faith traditions, multiple religion traditions support organ donation with varying emphasis on death verification, brain function, and life-saving benefit. In Judaism, generally permissive when death fully verified by circulatory criteria, consultation with rabbi recommended for observant families. Islam, interestingly enough, encourages organ donation as charitable act. And if there's not enough organs, they'll just go find you on the street and say, oh, what did you do? You jaywalker, taking your organs. It requires confidence in death determination, avoids doubt in declaration process. And for the Catholics and Protestants, organ donation acceptable when brain perfusion is excluded. That's very interesting. Somehow that does not surprise me. Recognizes donation as altruistic, affirms sanctity of the life-saving ability of this. So I find that very interesting that this organ, when brain perfusion is excluded, really falls in the Catholic. You're Catholic, aren't you?
Yeah, I am.
You too?
No,
No?
Protestant.
Protestant? Well, they're on here too.
They're on there.
Catholic and Protestants.
You asked me
Catholics
Dang,
and
you got both
Protestants.
of them, Joe, today.
I mean, Protestantism is nothing more than Catholicism light.
Yeah.
I mean, really, at the end of the day, everybody knows that. But it's very interesting because and there's this argument. It's kind of a crazy argument. I'll ask it. I'll ask it to you two. Do you practice any faith?
Hindu.
Hindu. Okay, good. Where does the soul reside?
In you?
In anyone.
Yeah.
I'm not sure I have one, but we're not talking about me personally. We're just talking in general. Where do you believe in your faith that the soul resides?
Within you.
Yeah.
But within
inside
you
of it,
where?
Yeah.
The heart, the brain,
All over.
all over.
Yeah.
So you
Yeah.
believe it's all over. You believe it's all
Yeah.
over.
All over.
You believe it's all over too,
Yeah.
because a lot of people, I don't know if it may be different in different sects, maybe Baptists or whatever. Who knows? Methodists, I'm not sure, but many people believe
It's in the heart.
that it's in the heart.
It's in the heart. Yeah.
Oh, that's
And I'm like, so, okay, you do a heart transplant, you get a new soul? I've had
Well,
these
there's-
philosophical arguments with people
gonna
about
say,
Say
that.
like when people say like I love you from the bottom of my heart, I don't think the people are saying like physical heart, right? Like the
metaphorically.
metaphorically
Yeah.
heart.
Yes.
Yeah.
Yeah. Well, I understand that.
Yeah.
Yes. Yes. Now, there's some people that I can only love from the very, very, very bottom of my heart, but that's a different issue altogether.
Yeah.
So, with that said,
Yeah.
global global NRP implementations. It's been a fun day. Active NRP centers. So you can see that the United States and Canada are very, very active in the NRP process. Also in South America, over here in Brazil, Southern South America, and interestingly enough, Colombia as well. And then these are emerging NRP. I think that says planned. Yes, planned emerging on the African continent in a variety of countries. And then here you can kind of look at this of what the emerging is programs, individual programs, because though it's all throughout the United States, it's not necessarily, it's very different in different states. But basically you can see even here in India, it's in the yellow, yellow-green. So that's kind of a challenging slide. I'm not sure really what that means. I think this is the one that I would focus on, and let's not concern ourselves with this one. And let's see how I do that. Yeah, there you go. U.S. transplant volume by organ. This is from 2023. Kidneys, of course, dominate.
Always.
Liver, heart, lung, pancreas, and intestines way down there.
Way down there.
Kidney dominance, it says here, represents 69% of total volume, largest organ category with longest wait list. Liver is second, and that's 26% of the volume.
You always take kidneys.
Discard impact. This is very interesting. So if we look at transplanted organs, we're here at 40,000. There are 7,412 organs, available organs, that were not used from 16,335 deceased donors, which is a 15% non-utilization rate. And the primary reason, warm ischemic damage, poor function assessment, logistical constraints, and recipient contraindications. Let's, for now, focus on these things because these are things we can affect. We can't really affect this. Okay? NRP potential could recover significant portion of non-utilized organs through the NRP process of physiological reconditioning, and the projected impact, even if only 5 to 10% of these were used, would the rescue rate would save approximately 400 to 700 lives annually. So it's not and that's only with 5 to 10%. You get it up to 30%, it's going to be more, right?
Yeah.
Significant more. So that's a lot of lives that can be saved with this process. So I'm very supportive of it. Prognostic error safeguards. While rare reports of prognostic error exist historically, meaning they said the patient was dead and it was an error or would not survive, modern safeguards ensure NRP protocols prevent patient harm through rigorous verification. Independent death declaration, separate attending physician verifies or whomever is going to, whatever provider, because sometimes it's a nurse practitioner, physician's assistant, whomever the declaring practitioner will be, verify circulatory arrest and death. No involvement in transplant team ensures objectivity. Brain protection verification. Arch occlusion documented, cervical cross clamp confirmed, monitoring confirms no cerebral perfusion throughout procedure. Again, I think
You're making a big deal about that as of late, too.
it is a huge deal.
Yeah.
Huge. Transparent documentation, of course, that's very important. And you have to, if something goes wrong, you got to tell somebody and you got to report it.
Yeah.
The slippery slope analysis and responses, ethical concerns and mitigations. Critics worry NRP may erode death determination standards, but robust governance structures effectively prevent mission creep or abuse. You can't erode determination standards if your standards are the heart doesn't beat and the heart hasn't beat for 5 minutes. I don't know how. I don't know how NRP can erode the death determination.
Yeah.
It's pretty black and white, in my opinion.
Yeah.
But regulatory oversight, registry accountability, and of course, public engagement. I do think the public does lack a lot of knowledge on this subject. But it leads me to this, and this is going to be a more, I think, emotionally draining part of this conversation. But this patient here was a DBD, not a DCD. He wasn't going to be a NRP case, but you can find the report. It's in the New York Post. I'm not going to get into the gory details of it. However, they were opening him up to take his heart for transplant, and he woke up and was alive.
Mm-hmm.
So he went on, this is his sister, and he went on to get married. Okay? That's what the public sees,
Yes.
and that's a problem.
That's a huge problem.
Okay,
Mhm.
huge.
Somebody
in
dropped
this
the ball
par-
somewhere.
then in this particular case, an 8-year-old was taken off life support and his organs donated, but now the police are investigating because they allege that the anesthesiologist, it was an anesthesiologist that gave the comfort medication, gave the patient a lethal dose of fentanyl.
Oh my God.
So comfort meds are by hospital protocol.
Correct.
If you deviate from that protocol, I don't know what ended up happening with this particular case, but it's a serious concern because when you get the prosecutor and the state involved criminally, that's going to have a chilling effect on anyone wanting to do this, right?
Mhm.
People are going to say, I don't want anything to do with that, okay?
Exactly.
That's a
I don't
high
want to be
volume
involved
center,
in
too.
that. But, yeah, Ronald Reagan UCLA Medical Center is a huge place, exactly. And so it'll be interesting. I'd have to look into it to see exactly what the outcome was. I didn't want to get into a big, long dissertation about it because they're troubling circumstances, but I think that it's appropriate for us to all kind of discuss our own experiences. And I know you have limited experience with NRP, but Mel, you have a lot of experience with NRP. Samir, you have a huge amount of experience in NRP, and I have a lesser but reasonable
You have a huge-
level of
you have a huge
experience in
amount,
NRP. Not nearly as much as you two do.
I know, but you've
But-
still done a lot. And
Yeah.
you've been around doing it for quite a lot longer than me.
But I know we've all seen, not really,
No, that's true too, yeah.
pretty minimal amount. No,
Yeah.
not really. That's not really true. But with all of that said, regardless, we all have our stories
Yeah.
and things that just make us go, do I really want to keep doing this? And would you mind sharing yours, and then you can share yours?
Yeah, I just had experience with like truly understanding how these candidates are selected as NRP case, because I remember coming across a case where like they extubated and the donor requested, well, prior to extubation, the parent requested a song be played during like the post
How old was
40.
So
40.
they were a special
But
needs?
Yes,
Okay.
autistic. Yeah.
Autistic,
And the
okay.
parent had decided to withdraw life support. But the donor clearly knew what song was being played. And of course, we're not allowed to be in the room or see anything, but we were just getting reports from the team. And apparently, she was just clapping along to the song and singing along. And that just was, knowing that was happening for what, 90 minutes? The donor never passed,
Oh,
but clearly she wasn't
Hmm.
going to pass. So then how do we get to that point, you know?
Yeah,
The
because-
GCS was like pretty high.
Yeah, mine
Yeah.
was, I had a
Yeah,
yeah,
case
so
just
why
like
would
that.
we even take somebody like that?
Yeah.
Mhm.
And that concerns me too, when I see GCSs or Glasgow coma scores that are 9, 10, 11, and it's like, what are we doing?
So
Why are we doing
yeah.
this? But when they take that donor back to whatever unit, they don't restart
No, they don't.
any care.
Mhm.
They just basically are taken to a
Like hospice, yeah.
hospice and left,
Mhm.
and they pass when they pass.
Well, there are sometimes they don't pass and they walk out of there, I've heard. I don't
Yeah.
have personal experience, but I've heard that.
You have heard that.
Mhm.
Yeah, that's very, and that troubles me way more than blood flow leaking to the brain.
Yeah.
Yes.
Way more.
Mhm.
Yes.
Way more.
Yeah.
Yeah, that had to. I have to ask? Did it make you second guess doing this?
Oh yeah, me and our PA, we were just really troubled and silent the whole time. We were not sure how to move forward. Who do we talk to? Like, you know, we didn't know at the time, but now I know to call you.
Yes, absolutely. absolutely.
Yeah.
Yeah. When they talk about the slippery slope, I'm going to talk about the slippery slope, but I'm going to talk about it from a different perspective. But before I do, you have a story.
It was a lot like Melissa's. I think the GCS was even higher than Melissa's. I would go as far as saying I think it was like 13.
Oh yeah. This
Like,
was 9.
Yeah,
Yeah.
so 13. This
I
guy
mean, mine's
is completely
probably
there,
only,
Joe. You know
mine's
what I mean?
probably
Like,
only 12.
Yeah.
If I'm lucky.
This guy was completely there, you know? And again, we're not supposed to see them, right? But of course, like me and Melissa were just looking at it, that happens. You have, you know, I
It's
was
pass-
walking.
it's in
It was
passing.
in passing. I was walking out of the OR. They were wheeling the patient in. It was supposed to be an extubation. A donor, sorry. They're a donor. It was supposed to be a extubation inside the OR. As, you know, I'm going, he sees me. He gives me a thumbs up. Okay, this freaked me out. You know what I mean? Like, considering what my role is about to be in the process, I, of course, could not stay quiet. I went straight to the cannulating surgeon, and I was like, what are we doing? Like, how was this guy chosen? What's going on here? Well, I like need an explanation of some sort. And of course, the explanation, of course, is we don't control this.
Mm-hmm.
It's done outside of us, between their that patient's doctor, the family. Decisions are made on another level that we are not privy to at any part of, which makes sense and we should not be, and I get that. But how do we get how did this guy get? How did this patient come in front of me? You
See,
know what I mean?
this
Like,
is what this is what concerns me. This
Yeah.
is what gives me pause.
yeah.
When I hear stories like that, and I'm not going to bother with any of mine, but they exist,
They exist.
you know, and it erodes, if anything, erodes confidence
I mean,
in the system. That's it. And yet, this is such an important, useful, beneficial, appropriate method
yeah.
for securing much needed organs, and when appropriately used is highly appropriate.
Correct. But then you have patients like mine with GCSs of 13. This guy was over-breathing the vent. I mean, all the
Yes,
signs are
a
there that
lot
this
of-
guy is not gonna, like, come on. Like,
Right.
I mean, clearly he's trying to breathe on his own. You're
I
just
know.
obstructing his own breathing with your little vent.
I know.
Like, he was completely there.
I'm assuming it's just philosophy. You know, it's
Yeah.
philosophy, and I don't know. I don't have any. I wish I knew. I don't know the answer.
I mean,
at all.
nobody did. I asked everybody when I was
asked
there.
them.
I was like, I brought it up, and you know, this is quite a while ago, but I brought it up with everybody. I said, what is going on here?
Yeah.
I needed an answer before I walked into that room, you know?
Yeah.
Backed into the OR. I just
Did they
didn't feel
pass?
right.
No.
No,
Yeah.
no, they did not
Oh,
pass.
you asked before.
Not even close, yeah, to
Mhm.
passing.
I was sitting there hoping
Yeah.
they wouldn't pass.
Yeah. I can understand that
Yeah.
too.
Me too. I would have
Yeah.
been bummed. And
I
I
can
think
understand that too.
he saved me, or he or she saved me from being very conflicted about what I was going to do by not
Mhm.
passing. I don't know
Yes.
how I would have handled
Yes.
that.
Yeah.
Mm-hmm.
If it would,
Mhm.
if the donor would have passed, I don't
Mhm.
know what I would have done. So thank God I wasn't put in that position, you know.
Sure.
But yeah, how do we get to that point, you know?
Mm-hmm. No, those are all really good questions. It makes me, I guess, what I'm thinking in my mind in real time, not have thought of this before, but thinking currently, that I would like to have even less knowledge and more protocols in place so that I know nothing more than the laboratory, body habitus, organs trying to be recovered, just the facts of the procedure itself and the donor's physiology and laboratory stuff, and nothing else.
Mhm.
Well, we usually don't until we get there.
Right.
Yeah, I don't.
But even while I'm there,
yeah, even while I'm
I-
there,
I wanna
want to be
go
in a
in-
separate room.
I want to set up.
Yeah.
I don't want to know anything. I don't want to. I don't want to know
Mhm.
anything.
So I've adopted that philosophy ever since that case.
Yeah.
Now I really do.
I don't want any
I stay away from
Yeah.
every part of it.
I don't want any.
If they ask me if I want to be
contact.
part of honor works, absolutely
Accidentally,
not. You know,
no.
no part of nothing. Keep
Nothing.
me away from it all.
Yeah.
Because, you know, I don't want want to be part of the beginning part because I've seen now what can happen. You know what
Yeah.
I mean? And
Right.
no, like if you're part of it is when you start to feel conflicted and this and that
Yes.
and
Yes.
and there's
mean,
a
for-
reason for that separate. They have that rule for a reason, and I now see why. You know,
Absolutely.
I mean,
Absolutely. Anybody may, let's see. Though you may interested in Bradley S. Allen, 22 studies of isolated global brain ischemia. I'll have to look that up. This comes from, this looks like, I can't tell
you
what
won't
kind
be
of
able to
writing
read
it
that
is.
name, Joe.
It's
unless you can
Asiatic
read-
writing.
Yeah.
Can you look that up, Magic, and see what it is? Anyway, obviously I believe that the NRP process is a good process.
It is.
I do think it's evolving. I think it will get better. I do think that individually as clinicians and practitioners, we have to protect ourselves and less involvement, which is really just no involvement, which is the protocol, is not even accidental. I don't even want to accidentally pass
That's
the
yes. And now I do a good job of
and
maintaining.
I'll tell you something
distance
else I think they need to do. They need to stop doing the huddles
in the
unit, where
yes.
they are, because
I
I
agree.
walk in and we're directed to a certain place.
I agree.
But I've been in hospitals my whole life. I can see a grieving family from a mile away.
I agree.
I
agree.
and they look at me and I look
Yeah.
at them, and it's emotionally distressing.
It is emotionally distressing, but there's a certain challenge to not having it there. The care team can't be that far away either. You know.
No, but they can. No, but okay. Let me throw this out at you.
Mm-hmm.
Instead of that as an argument, how about figure out a way
There you
that
go.
you can bring us up there
Mhm.
in an area that's going to be close enough for you, but you,
Yes.
as whomever the coordinator for the OPO may be, you make sure we don't have any visual or otherwise contact with the patient or patient's family, or
I agree.
donor's family.
I agree.
How about make that your responsibility and put that in the protocol?
I agree. And yeah, I mean, they don't want to see us. We don't want to see them. It's a kind of a two-way street, right? Like,
Yeah, I don't think they have as much problem with seeing us as we have of seeing them. I wouldn't think.
I think I would. I don't know why. I would. Maybe
You-
because I
you
know
know
the
more.
process.
Yeah, you
maybe
know
because I
more.
know the
Yeah.
process. Now that I know the process, I would not
No,
want
I
to
mean,
see.
I think all of these families are making these decisions. I think it's horrible that they have that
horrible
they go
decision.
through this,
Absolutely.
right? But they're trying to take an incredibly just an incredibly terrible situation and find some solace that it did some good. So, I mean, I can understand that. I mean, that makes sense to me.
I think that's the main reason they agree to do it is, to try to give them at least one positive memory of the event towards
Yes.
the end, right?
Yes,
Like,
agreed.
I mean,
Agreed.
and then they
told
try to
you.
hold on to that positive
I've
memory
told you
going
before,
forward.
but I could never imagine like pediatric population.
Oh,
like
yeah.
No,
that.
I won't. I
that's-
can't do it. I won't do it.
Yeah.
no,
And
no.
it's very interesting because Texas Children's will not permit, will not allow. It is forbidden. It is excluded 100% in any of their institutions to do NRP.
Wow. Oh, really?
Yes. And yep, it is disallowed.
Is that recent?
No.
It's
Oh.
always been.
Oh,
that
it's
way.
always
Wow.
been. Wow.
I couldn't pump it anyway, so that's
Yeah.
fine. I don't. I
And
couldn't.
there's the
I wouldn't have my head
selected
on straight in that
the
case.
selected references. Okay. Well, I know I went a little over on that. I apologize for that.
It was a heated topic.
It is. Are we allowed to take a minute or two break so that I can do something with my slides? Can we take, how about, can I get 5 minutes? Okay, we're going to take a 5-minute break. Oh, shit.
I got it.
Thank you.
Yeah.
I curse online all the time. It's
He
terrible.
does regularly. It's always when something
Yeah.
like this happens.
When I was at the New Orleans conference, it was
On stage, no.
we were doing it. No, we
Oh.
were doing it. We were doing it down in New Orleans, and we were airing it also at the same time.
Mhm.
And I forgot that I had a mic on, and I was just in the general
hot
audience.
mic.
And I was just in the general audience. I was talking to somebody, and somebody called me up, and they said, "Dude, that's a lot of f-bombs online." I went on this big long diatribe, and I was like, "Ah, man," and it was on YouTube
Oh, no.
forever. I think it's still there.
Oh, God.
I think it's
We'll
still.
look it
I
up.
think it is still there.
Dig this up.
Okay.
I don't even know.
You guys want to stay? You don't have to, but you can if you want. I just have to fix one thing.
Are we
But
on-
you don't have
Are we
to.
on the break now?
Yes.
Oh,
Yeah.
okay.
Oh yeah, we're taking 5 minute. We need a 5 minute break. Didn't I just?
All right. Well, welcome back. Yeah, well, Joe is working on his thing. I guess let's take a second and digest what we saw earlier. So yeah, I mean, I've been privy to doing a good amount of NRP cases over this last year, or so. I feel with NRP, I get why a lot of the stuff happens, like how we were talking about how you can accidentally see a patient on the way out. They're very chaotic. And I feel like every case is different than the case. There's no real structure per se in any one of them. Maybe that's exactly what we need. We need more structure. Some of them are more structured than others, some are not. And God forbid you're taking like lungs, liver, heart, kidneys. If you're taking everything, then you got so many teams there that it's just, you're for sure not going to be able to avoid people, patients, or anything like that. So, I mean, again, I get that the challenges can be kind of real, to try to create structure in chaos. But I feel that's what NRP needs, In my 1 year or so that I've been doing this now, I don't think any two cases have ever been the same. With regards from a point of how to the point of getting on pump. From the beginning to the point of getting on pump, it's always been different. Every one of these cases is a little different. Whether you're huddling here, there, ICU, you're huddling in some room on the side of the ICU, it's always different. There's never a set way that things are done. Maybe that's what this needs. I mean, personally, that's what I think. After doing this many cases, that are all unique, maybe it shouldn't be unique. The unique part should start at incision, because that is going to be unique. It's the part where you're going to go in, and that, the surgical aspect of it, the clinical aspect of it inside is the different part. Now, it should be pretty structured and the same from the beginning. I personally believe that is where it would help a lot at the beginning too, mitigate some of the chaotic damage that's done. I'm sure Joe would agree if he ever gets around to doing this, finishing what he did. But these cases they're all just a different level of chaos. Each one of them is chaotic. It's impossible to be in one that's not chaotic thus far. I've never seen one that goes structured. So, it's just, how do you stop doing this? And that, I think, is where the naysayers also find their fuel, is chaos, the lack of a proper structured system. So you can find, stuff that went wrong in almost any case. Every case is not done by the book like it should, because there's no system. Ethics is a big concern. For NRP, like Joe said, I think it's the largest concern for NRP. Personally, I never really thought it was a big deal until that one case that I brought up, and then now I can't think straight after that. So structure, I mean, that's what I think would help. But
I think so too.
yeah.
So going back to, let's see, are we live again? Yes.
Yeah, we're live.
Okay. Well, I'm not. My computer wasn't live.
Oh,
anymore.
okay.
I did want to also point out too,
Yeah.
that this individual, I can't read
The name, yeah.
I don't know if that's Japanese. I don't know
Mandarin,
if that's Chinese. I don't know.
or, yeah.
But it says hello. Oh, he looked that up. Okay. So
Cool.
I did just briefly pull up that study of
Mhm.
Bradley S. Allen, and I'm going to have to read it. I have heard of these things about up to 30 minutes of brain ischemia, that you can have brain recovery. I've heard these things, but I think that, and there's apparently a process. I'm gonna read into this, and I probably will do a follow-up to the previous
Yeah.
conversation that we had, the previous
not
lecture on
saying-
NRP. But I know that I do recall people saying that it's the oxygen that's the problem.
Correct.
So I'll have to see exactly what they did here, that tested after 30 minutes of normal thermoglobal brain ischemia and so forth, that they had these return of neurologic function. I'm assuming these are animals. I'm not really sure. Again, I have to read it. But with that said, you usually, if you have a patient who has circulatory death, acute, sudden cardiac death, and you're concerned about neurologic injury, you tend to keep their PO2s very low.
Correct.
In order to prevent the reperfusion injury
Correct.
process, the reactive oxygen
Absolutely.
species, the oxygen radical process, all production, all of these
Correct.
things. And so I'll
You
have
tend
to look
keep
it
the
up.
CO2 higher,
But
and
you-
decrease that while increasing the oxygen.
Yes.
Very in a stepwise fashion.
Yes.
Very slow.
So it is interesting to bring this up. I still believe that because we are there, we have very high PO2s, very high DO2s. We're doing everything that would be counter to trying to recover severely ischemic tissue
Right.
of the brain. The brain is very sensitive to this. And it's not unlike the process of when you have an MI. You have a big infarct of the heart, and what is the last thing you do when somebody has had an infarct, an acute myocardial infarction? What is the last thing you ever want to do?
Restore blood flow right away.
Correct.
Yeah.
Do not do it,
No, you don't. Yeah.
because you will extend the
Yep.
infarct.
Yep.
So when they have an acute MI,
Mhm.
and you revascularize it,
Yep.
either by surgery or whether by stent,
Mhm.
if they're ischemic, that's fine,
Right.
okay?
Yeah.
They're having severe angina.
Mhm.
But if they've had an infarction
Mhm.
and you restore blood flow to that area,
Yeah.
you will take an infarct that's this big and make it this big, and they're dead.
Yep.
I have to assume, and I do assume reasonably, that the brain does the same thing. Okay, I might go through this quicker because I know we're way behind time, but that first topic was so good, and I think everybody did a really, really good job with that. Okay, you ready? Okay, let me pull this back up. So, looking here, here's our learning objectives. I won't go through them. I want to go through this fairly quickly. What is hemodynamic monitoring? Measurement of pressures, flow, oxygenation with cardiovascular systems. The purpose is to assess cardiac function and tissue perfusion, or your artificial circulation perfusion, guide therapeutic interventions, fluids, inotropy, vasopressors, detect early signs of cardiovascular instability, evaluate response to treatments, and the key parameters that everybody looks at: heart rate, we want ours to be 0 when under cardioplegia, arterial blood pressure, central venous pressure, pulmonary artery pressure, cardiac output, and systemic pulmonary vascular resistance. Now, very important to say here that we assume our CVP will be close to 0 because we're on full cardiopulmonary bypass, unless you have an obstructed drainage problem with your cannula or the pump. We rarely look at pulmonary artery pressure on pump, but it sure as hell is nice to have and look at while you're trying to wean the patient from bypass. It gives you an awful lot of information,
It does.
and we're going to talk about that because monitoring is only as good as your monitoring is.
Correct. Yeah.
And of course, cardiac output, we definitely do measure that. PVR we rarely look at, but SVR we look at all the time, and or at least you should, and it is a clear indicator of what you're doing. But again, it's very important. You can't measure SVR if your arterial line is not measuring properly.
Correct. Yeah.
You will get a bad number.
Yep.
The perfusionist role in hemodynamic monitoring, pre-bypass, baseline assessment, you want to check and see, what is the blood pressure? What is the CVP? What is the PAD? What's going on with this patient? What do they look like preoperatively, so that I know when I'm trying to wean from bypass, if you're the one who weans them, if you're not directed on how to wean, which I won't do. I refuse to let anybody tell me how to wean a patient from bypass. But with that said, moving on from there, you want to know what you started with to understand what's going to be back to baseline, and if you're looking better or worse. During CPB, you want to maintain your target arterial pressure and flow on bypass. Of course, you want to be above a value. We run our mean arterial pressure so low on bypass compared to what is normal.
Right.
Everybody, and there's reasons for it, I understand that, but everybody freaks out when they see a mean arterial pressure of 90. Well, that's kind of normal.
Yeah.
You know, but your cannula is going to come out. Well, not if you tied it in well enough, it won't. There's all kinds of things like that go on. Monitoring CVP for adequate venous drainage. You start seeing your CVP creeping up and your level is going down to your oxygenator. You can add 1 and 1, get 2, and you know what the problem is. Observing PAP for signs of pulmonary hypertension or volume overload during partial bypass or low flow states, or you're doing a beating heart, on pump beating heart, non-clamp. Interpreting trends in relation to temperature, hemodilution, and drug effects. Weaning from CPB, crucial for assessing myocardial recovery and volume status, guiding pharmacological support and fluid administration, and anticipating and responding to post-bypass complications. Post-bypass, collaborative interpretation with surgeons and anesthesiologists. You may have a bunch of volume in your pump left over. You shouldn't if you hemoconcentrate it effectively. You should have very little, actually. My goal when I come off pump is to have nothing. I want no cell saver blood given to the patient that came from what was left in the pump. If it was from bleeding for other reasons, that's not an issue. I don't want to have a bucket full of blood that I now have to process to the cell saver. So I aggressively hemoconcentrate and flush everything through. I want the lines to be clear so that I've given the patient all of their whole blood back. That's very important to me. But you need to understand it because you can look up. Anesthesia might be, busy looking at a text or looking at the stock market. No one ever knows. The surgeon has his head in the chest and he's trying to find what's bleeding or he's trying to put a stitch in or, whatever's going on. Well, you're there and you look up and you see the pressure's low. You see the CVP is low. You see the PAD pressure is low. You know the patient needs volume. You can say, hey, do you want a couple of hundred? Being engaged, I guess, really is the point I'm trying to make. But you got to understand hemodynamic monitoring to know how to be engaged and what to do, right? Key hemodynamic parameters overview. I mean, you can look at this yourself. It's pretty self-explanatory. Does everybody here know how to calculate the SVR when you're on pump? I'm just curious if everybody does or not. So for those of you who don't, if you go to our app. Do you have our app? Can I share my thing and open the app? No. Oh, open it on the iPad. Shoot, I am so sorry. I'm doing it on the wrong. I'm sitting here doing it on the wrong thing. Sorry. Yeah, got it. So there's 2 ways to do this. You'd use our app, and you could use hemodynamics. It's in the perfusion section as well. But you can go there. You can type in SVR. You can put you're on pump. You're flowing along. Your mean arterial pressure is 62. Your CVP is 0, essentially. You're on full bypass. And your cardiac output is 4.8. There you go. Yeah, calculate. Your SVR is 1,000. That is perfect. Perfect. Now, if it was that and you were flowing 5.5, it's still perfect. It will give you a map of 52.
Yeah, it's going to be a little less.
Okay? 755, that's low. That patient could use some phenylephrine or some norepinephrine in order to get that SVR up. I like to come off bypass with my SVR unless there's a really sick ventricle. Otherwise normal ventricle, I want my SVR to be closer to 1,200 than closer to 800. Okay? But, so take these numbers down real quick. Okay? I'm just going to do them. 60, 2, actually I lied. 62, 2, and I'm going to make that 5. calculated, okay? 959. Now, I'm going to take my trusty pen. How do we calculate this on pump? I take 62. I'm sorry. I can't, it doesn't work that way. So remember these numbers. Just, can you?
62, 2, 5, I got it.
Yeah,
Yeah.
62, 2, and 5.
Yeah, I got it.
Okay,
I'll
so go back
remember
to PowerPoint. And let me go to, I'll just do it right here. 62
And you got it
minus
from-
2
Yep.
equals 60 times 79.9, but for convenience, make it 80. 6 times 8 is 48, divided by 5, no, divided by the cardiac output, 5, which is 5. 5 into 48, 5 8s are 40, and so 5 into 48 is 5 is 8. That leaves 8 left over. So approximately 8.2.
No.
So lower, but I did it by 80.
No, 5 into 48 is 9.
9?
Yeah.
I'm sorry. 900. Thank
Yeah,
you.
There you go.
5 9s are 45, right.
Yes.
So a little over 900.
Mhm.
And what was, thank you so
Yeah.
much. And the actual
Nine-
number
940
was
something. So you're close.
959.
There you go.
So that's a simplified version, as long as you do your math correct. Very easy to do that formula.
Yes,
Mean
dementia people, don't
arterial
forget.
minus the CVP times 80, it's 79.9 per actual formula, times 80 divided by the cardiac output. So easy to do. And you can do it like that. And you can tell when you're getting ready to come off bypass, what's my SVR? Am I ready to come off? You can always use the app. I'd prefer you did that. But you can calculate this in your head. You don't even need paper, right? Okay. Understanding normal hemodynamics, systolic normal is between 90 and 140, diastolic 60 to 90, mean between 75 and 105, maintained between 60 and 65 during bypass, and during the initial post-op period to avoid any kind of disruption of the aortotomy that was done for the aortic cannula and for the cardioplegia. Normal arterial waveform has an upstroke. This is ventricular contraction. It has a delayed upstroke here where the ventricle is still contracted but empty. And then you start to have a runoff because there's no flow. And this is your dicrotic notch. What? Yes. Oh,
Yeah. He didn't do
I
anything.
don't know.
Yeah, he didn't push nothing.
I don't know how to unshare.
He was just,
I don't know how to unshare it. I'm sorry. Not sure what I didn't do anything except,
he was just drawing.
yeah,
On the
this.
screen.
Let me take that off. I mean, I can close it. Okay, that worked? Okay.
It did.
Sorry. Okay, so we'll go over that again. So you have your ventricular contraction. The ventricle remains contracted. You have a rapid ejection phase, and you have a reduced ejection phase, followed by a drop in blood pressure. And here at the dicrotic notch, the aortic valve is closed, and you get some coronary perfusion in this range, some, but it's minimal. Your maximal coronary perfusion is from here to here, with the pressure, as you can see, coming down. So it's passive filling. There's pressure, but it's mostly a passive fill of the coronaries. Understanding normal, so normal ranges, we discussed that for the pulmonary artery system. We did the arterial. 15 to 30 so for systolic. 25 over 10 is normal by textbook, generally speaking. Mean around 9 to 18, but really this is the number I look at most. Although you do need to look at this just to concern yourself with perhaps pulmonary hypertension, but pulmonary artery diastolic pressure is a great indicator of left ventricular function. Your wedge pressure, when you put the catheter all the way out and you inflate the balloon, should be lower than your right-sided pressure, because blood has to flow from high to low, and that's going to be between 6 and 12. Normal pulmonary artery waveform looks like this. This is, if it's ventricularized, you're going to have a diastolic pressure. No, that's not right. This is, oh, that's capillary wedge pressure. I'm so sorry. Your pulmonary artery pressure is very much like the difference between an ventricular pressure and a aortic pressure. You have a valve in between, but this is your wedge pressure reading there. Systolic upstroke and peak reflects right ventricular ejection into pulmonary artery. Your dicrotic notch indicates pulmonary valve closure. That's here. Your diastolic runoff is here. And difference from A-line, low pressure, often more rounded peak and more gradual diastolic slope. And the wedge waveform, when balloon inflated catheter wedges distal pulmonary artery reflecting left atrial pressure, shows these waves similar to CVP, but slightly delayed. And that's this left atrial pressure waveform you should see here. We won't get into that too deep. Understanding normal right atrial pressure. This is good. Measure right atrium or vena cava via central venous catheter reflects right ventricular preload and systemic venous return to heart. Normal ranges in adults are 2 to 8. In cardiac surgery, it is more common to see between 10 and 15 for cardiac surgery. Physiological significance estimates right ventricular and end diastolic pressure, indicates intravascular volume status, though imperfectly, reflects balance, and that's very important. Reflects balance between venous return and right ventricular function, and crucial for managing venous drainage during CPB. Now, if you have a rising CVP and a falling PAD, that is reflective of what?
Right ventricular failure.
You are correct. Right ventricular failure. Normal right atrial pressure waveform, I'll just go over it very quickly. You have atrial contraction. You have the tricuspid valve elevation into the right atrium as the valve is closed by ventricular contraction. Then you have downward movement of the contracting left ventricle because it's pulling the contraction, the papillary muscles are pulling that valve down. And then back pressure wave from the blood filling the right atrium again, and the process starts over again. Understanding this waveform is important in order to be able to determine if your patient may have tricuspid regurgitation, where you will have a large V wave here. And it's the same thing with the pulmonary capillary wedge pressure. You will have, you will have a very prominent V wave,
right.
and that is indicative of mitral regurgitation, right ventricular dysfunction, and arrhythmias. On bypass, perfusionist controls pump flow and manages SVR to achieve target map between 50 and 70, measured from the A-line or pump. CVP, we want it 0 to 5. Closer to 0 is always better. High CVP may indicate cannula malposition, kinking, or venous obstruction. And a lot of it's just they're pulling the heart over and it's just not draining. Yep. Pulmonary artery pressure monitored reflects residual volume. Venting may rise if lungs distended or residual pulmonary flow. That could help you identify something like a persistent left-sided cava.
Yeah.
You know, there's a lot of things you can diagnose. Your PA pressure. Why is my PA pressure so high?
Yeah. And
I'm on pump and my CVP is 2. This doesn't make any sense. Yeah. Extremely important for weaning off bypass. Yeah. And we discussed that already. Recognizing poor waveforms. This is the Achilles heel. The waveform that appears flattened, blunted, or less defined than normal inaccurately represents true intravascular pressure. So I'm going to throw this out at you, and you tell me what you think. You're on pump. You have a 21 French
Arterial.
Medtronic, whatever,
Soft flow.
arterial cannula,
Sure.
soft flow, whatever
Yeah.
you want to call it.
Yeah.
And you are flowing 5.2 liters, and your arterial line pressure
Mm-hmm.
is 230,
Mm-hmm.
and your arterial pressure, mean arterial pressure,
Mm-hmm.
is reading 38.
Hmm.
What you gonna do?
Well, with the 230, you can still go up and flow. With the 230 arterial line pressure,
Think about it now for a minute. Look
Yeah.
at the title.
poor dampened wave.
Think about it for a minute. Think about it.
Go down and flow.
Something wrong.
Yeah, something's wrong.
Okay. Something's wrong. Those numbers don't match.
Yeah.
That's poor. That is a damped or malfunctioning arterial pressure indication or
Sure.
pressure on the monitor. That could be for a variety of reasons. They're leaning on it, poor placement,
Mm-hmm.
transducer's been knocked off its mount. There's a reason for it.
Mm-hmm.
But if all you do is look at a number 38
Mm-hmm.
and you say, I'm going to give her 48 or whatever, and I'm going to give Neo,
Mm-hmm.
if you calculate your SVR, Neo would be indicated.
Mm-hmm.
But you're calculating your SVR on bad numbers.
Yeah.
How many times
Yeah.
have you heard me say, and I say it a lot,
Mm-hmm.
I don't trust that arterial line
Yeah.
at all.
Yeah.
You gotta think about that.
Yeah.
It is such a common
Yeah.
problem.
Because you're pushing against something with a 230 line pressure, right? Like you got some sort of, you're pushing against something.
Well, you have to look at your line pressure and what size cannula you're using and what your
Right.
flow is.
That's what I
And
mean.
what's important for us, I think my takeaway message from this is learn what the pressure drops are, not from the data sheet. Just do it yourself.
Sure.
You do enough cases,
Mm-hmm.
you go, okay, normally I have on my cases, when everything's working perfectly
Right.
and everything, I have high confidence in everything, and I flow this much,
Mm-hmm.
my line pressure's that.
Yeah.
So when you look at your pressure and you
Correct.
go, man, that's
Yeah.
awfully low, I've got good flow,
No, yeah.
but wait a minute, my line pressure is matching this. And on the last 10 patients I did
Mhm.
with a mean arterial pressure of 70
Mm-hmm.
or 75, I had a 230 millimeter arterial line pressure at this flow.
Mm-hmm.
So why is it now such a difference in pressure drop? It could be something else more perhaps dangerous,
Yeah.
but it's more than likely bad arterial.
You can also look at your flow. Like if they're leaning on it, that means it would have just happened.
Correct.
So if it's a 38 that just happened and you're using a centrifugal pump, then your flow would have gone up because you're pushing against less of an afterload, right? So
Yes.
so
correct.
Now if you're still flowing the same,
That's another.
Yeah. Yeah.
Really good point.
Yeah.
That's what we do for a living. Is
Yeah.
we figure these things
Yeah.
out in real time, extremely quickly.
Because that has happened to me. I have had that where the surgeon's like, "Is that my real map?" I was like, "I don't know. I'm still flowing the exact same, so I'm assuming that our afterload is the exact same that it
Exactly.
was before."
Now I didn't get go ahead and throw the slides back up. So I want you to see this right here: severe vasoconstriction. And there's a reason for that. But there's a variety of reasons why your line doesn't work well. Most of it is because anesthesia likes to use these little teeny short lines instead of putting one in like this all the way up into the brachial. I don't know why they don't do that. The longer arterial lines in the brachial is such a better place to measure from, but you can't convince them to do it. They just want to put those little teeny short
Into the
ones
radial.
in, and they're terrible at
Yeah.
securing them. You know,
Yeah.
some aren't, but most are. So there was a case. I didn't do the case.
Mm-hmm.
And they could not get the arterial pressure up. They couldn't get it up no matter what they did.
Mm-hmm.
They gave Neo and Vaso and Norepi and you name it. They were almost going to give angiotensin II.
Oh yeah.
They were getting that close.
Yeah.
It was insane.
Yeah, that's bad.
And they couldn't get the blood pressure up. And nobody noticed
Mm-hmm.
that the flow kept,
Mm-hmm.
the line pressure kept going up higher and higher and higher, and the flow, they couldn't even get the flow.
Mm-hmm.
And the patient died
Mm.
from a massive I guess it would be anoxic.
I was about to say it'd be
brain
an
injury.
Yeah, it'd be an anoxic
Yes.
brain injury.
Yeah, anoxic brain injury.
Mm-hmm.
They were treating a false number, and they were literally pouring bottles of vasopressin in.
So they
And I was
constricted
like,
and
what
lost
are
flow.
you? What are you doing?
Yeah, yeah.
Wasn't my case. Wasn't my case, and it wasn't where I worked.
Yeah, it would be anoxic.
I was like, whatever. I mean, this. But then I heard about it later.
God, especially angiotensin too. That's
Well, they were bordering on giving it.
Oh, okay, they didn't.
They
Okay,
didn't,
I was like that.
but they were
That
bordering.
restricts everything.
They were bordering on giving
that
it.
would've
They
done the-
didn't.
Like,
When I heard
if the
them say
brain
they
would
were
have
gonna give-
survived, their kidneys would never have
When I
survived.
heard when I heard they said they were going to start, they were going to get, and somebody said, get angiotensin II. I was like, dude, I think I've seen enough of this case. I
Yeah.
just sort of backed out,
Yeah.
and and I was able to find out what happened to the patient, but it was stupidity at every level. That's all I can tell you.
I mean, somebody in there
Um,
didn't think that, like, let's check, or get a new art line in, get a new
Just
anything.
telling you, dude.
Yeah.
Dude, not every, you know.
Ours was, mine was obvious. It was 12. Like that case that I was just
Yeah.
talking about. Like, it wasn't 38 or something like your numbers that
Yeah.
were. It was obvious that something's wrong with the art line. It was like 12.
Exactly.
And I'm still having an afterload that I'm pushing against. Surgeon's like, is that number real? I was like, I don't think so. I'm pushing against something greater than a 12. Is what
Yes.
I said.
Exactly.
So
exactly.
that was my response.
Exactly. So anyway, back to this. Causes of damp waveforms are listed here. There's a whole variety of reasons. It can be all of these things, including the surgeon, especially if they have a big belly pushing on the arm, and occluding it. So that, or the assistant, whichever one. It happens all the time, and you have to be aware of it. Troubleshooting damp waveforms, there's a variety of ways to do it. One of the things that you could zero it, and then you can flush it, and you want to see a big square waveform and all of these things, but these are the ways that you can do that. So let's look at clinical scenario 1, sudden drop in mean arterial and CPB with damp waveform action. Rule out the artifact first. If true, increase pump flow. Consider vasopressor. Check crit, temp, anesthesia. You were right on yours. Scenario 2, there's an elevated CVP during venous drainage on CPB. Your action should be check for cannula kinking, malposition, adequate vacuum if VAVD, patient position, and how far out of the chest the assistant or the heart holder is yanking the heart so that they can get to the back side of it. And sometimes you just got to say, look, if I'm going to stay here much longer, I got to cool this patient.
Yeah.
I know you got to do the operation, but I got to do something. I cannot stay warm while you're doing all of this. That's where you need to be thinking, right? Post-CPB, PAP begins to rise significantly. Action, collaborate with surgeon anesthesia, assess LV function, wedge, consider pulmonary vasodilators, optimize ventilation, oxygenation, and sometimes it may be, you guys want me, if protamine hasn't been given, you want me to take a couple of hundred off?
Yeah.
Drain it.
Drain it,
You can drain it back from the arterial if the venous cannula is out, or you can take it out of the venous if it's still in. It doesn't matter. Just don't do it rapidly. Just take your time. I mean, everyone likes to wrap.
That was
So
just
you
what
know
I was
what?
saying.
You can wrap the arterial line. Don't tell me you can't. Oh, I'm not going to go backwards through the arterial line, except when I want to wrap.
Wrap your
right?
200.
And then patient weaning from CPB, A-line is damped, action, perform square wave test. That's that flushing thing I talked about, troubleshoot catheter system. If still damped and patient's damp and patient stable, rely on NIBP and clinical assessment, consider a new A-line. Well, I wouldn't do any of those things. What I would do is I would connect I would get them to clamp the arterial line, come off pump, say, look, I know it's higher than that. No, it's not. I'm telling you it's higher than that.
Yeah,
no,
that's
it's
kinda
not.
what I was
Okay,
doing.
get 2 clamps, please. Clamp the arterial line, proximal and distal to that little white cap. Take the little white cap off hand a pressure monitor line to anesthesia, connect it to the same transducer. They're transducing the radial, flush it. As they're flushing it, connect it, and then take off the distal clamp only. Don't take the proximal clamp
Correct,
off,
yeah.
the distal clamp only. And that is going to give you a very accurate central arterial pressure. Compare them to each other, flip the switch back and forth on the stopcock, and look at the difference in the pressure. And then the surgeon will generally say, okay, get me a femoral arterial line kit. I want a micropuncture. And they put a femoral arterial line because anesthesia doesn't know how to put in radial arterial lines. Okay. Conclusions and takeaways. Bad information leads to bad outcomes. It is our job to recognize bad information. It's also our job to understand what is normal. It's our job to understand what's abnormal. It's our job to understand what we can do to either ourselves or suggest to make abnormal better. Thank you. I know I went through that quick. I apologize for that. Yeah, I know. I'm sorry, everyone, for going through that so quickly. I hope you don't mind. All right, any questions? Questions from the audience? Do we have any feedback, anything at all? Nope, nobody's saying anything? There's people online, but nobody's saying anything. I guess I'm glad I didn't make y'all get that phone line to work. There's no one's ever going to call us. But I still want a phone line. I want the phone line, okay?
For that
David,
one,
Magic,
you did get that call.
and I want my lights to work. All right. With all of that said, let me give you the good news. There's good news and there's bad news.
There you go.
Which do you want to hear first?
Bad news always first.
You always want the bad news first?
Always. That way I can end it on the good news, and feel good about myself after.
Okay.
Yeah, that's a standard protocol. I worry about the people that want the good news first. Are you one of those people, Joe?
No, but I like when
Okay.
people say they want the good news because I give them really crappy news and they go, that's the good news? Well, what's the bad news? The bad
See?
news is there is no good
It's
news.
people like you that's the reason.
See, that's what I like to do. Okay. I do have a comment from Spain.
Greetings from Spain.
Yay, somebody from Spain. Greetings from Spain. Very interesting talk. Thank you. Thank you. Is it, what's his name?
Soren?
Soren.
Soren. ZMC.
Maybe it's Sal
I'm
something.
probably butchering it.
Maybe. Yeah.
We're
Welcome.
probably-
Hey, buenos dias.
There you go.
Yeah,
there you go.
Throw some Spanish out there, boy, right quick.
Go.
Okay, we're in Texas.
Exactly.
Now we speak
We know-
Texas version.
yeah, we know
We
a
have
little
a
bit.
Texas version of Spanglish down here. What's that?
I said we know a little bit.
Yeah, exactly, exactly.
We can get by.
The good news is we are going to do, or the bad news is,
There
you
you
want? I'm gonna give you the good news. The good news is we are going to do PerfWeb 108 Day 2 next week. The bad news is the last time we tried to do ECMO circuit design and simulations with the, with
Vicky?
the circuit and fluid and all of that stuff, it was an epic disaster. And I don't know if you can spin your camera around, David, or not, but if you take a look around the studio, you can see that we have a lot going on here. There's a
Yes,
lot of
there is.
technology. There's cameras everywhere. There's lights everywhere that they never seem to want to turn on for me. There's a big green screen over there.
There is a
There's
big screen.
sound absorbing boards over here.
There is.
There's televisions over there. There's all kinds of high dollar computer
There you
equipment
go. Look at that.
over
Now they get to
there.
see.
Yeah, we're going to do a 360.
Look at this.
High dollar computer equipment over there. And we had several mishaps with the circuit and fluid and all of that stuff. You going to be able to go all the way around or only like half and half?
I feel like he just cut himself out. Did you notice that?
He does that,
went-
that, of which
he
I just
went
got
to
through. I
himself
just got through talking about
and
all
then
the
stopped.
technology that we have.
Yeah.
And what does he
He didn't
do? He
even
doesn't
include
show it.
that.
Can you please go all the way around this time?
You can always hide
You can
behind your
hide
monitor.
behind the monitor.
Yeah,
They
you can
can't
hide behind
see
your
you.
monitor.
All they can do is see the top of your head, David, for Christmas sakes. That's all. That's okay. Well, it's as
by
far as it goes.
design, you say, huh?
Yeah, by design. Well, take my word for it. There are
Yeah.
There's a lot of computer stuff over there, and we had fluid
Everywhere.
spraying with glycerin in it.
Oh my god.
And I don't know how we missed the cameras that were all on, and had we hit those, it would have fried them.
Oh my god.
So I am not doing that again. I will announce what the alternative lecture will be. It will be something about ECMO circuit design, but it will not be simulation. So I'll do a really good comprehensive review of ECMO circuit design.
Okay.
And we'll do visual computer-generated simulation as opposed to real system simulation with
Sure.
fluid and all of that kind of stuff. And it's the only way that I can do this and feel like I'm not going to destroy this place.
Yeah, that's fair. I mean,
Fair enough.
There's a lot of money in this place, like you said. I get that.
It's-
I get that you wanted to do it,
Yes.
and it's just logistically doesn't make sense.
Yes. So everybody have a pity party for me,
There
because
you go.
I do spend a lot of money bringing these programs to you from a technological perspective. We have people that do the stuff back there that air it and run all of this technology. You have
It's true.
us up here. You have the infrastructure of the office and all of the studio and all this stuff. When we do our ECMO course, we have, of course, content experts. We pay those folks to come here. Sometimes some come as a guest, like you're a guest on Content Expert. You don't cost me anything, thank God. I'd be in the poorhouse. So, again, why it's so important that I even bring that up, subscribe to our channel,
There you go.
send it on to your friends, colleagues, have them subscribe to our channel, and it would be incredibly helpful to us because it drives more people to our programming and to our perfusion education platform for them to get their CEUs. We don't make any money out of this. I'm losing money continuously, have been for probably the past 8 years, 5 to 8 years.
Yep.
But if I could at least reduce the bleeding, maybe my bone marrow can produce a little more red blood cells before I die from exsanguination. Thank you.
There you go.
See you all.
See you later, bud.
See you all next week.
Yeah.
Bye. Bye.